Good morning, everyone. My name is Kathy, and I'm going to be doing the EMCCM lecture today. So we have a 31-year-old male with a suicide attempt, just to get your thoughts sort of flowing. And I want to thank the EMCCM team and our guest reviewers for helping me with this lecture. So EMS comes to you and they bring in a patient who's 31 years old. He had a suicide attempt by ingestion about 30 minutes ago. They didn't really do anything for him yet. And they're on their way trying to get the pill bottle for you. His vital signs: heart rate is 89, respiratory rate is 18, BP is 152/88, temperature is 98. He's saturating at 98% on room air, and his finger stick is 180. So our initial assessment, his airway is intact. He's speaking normally. He has bilateral breath sounds that are equal. His distal pulses are normal, as well as his blood pressure and heart rate. His mental status is also normal, and he has no deficits. So a little bit more about his history. We found out that he was gambling. He lost a lot of money. He tried to ingest an entire bottle of an over-the-counter medication 30 minutes before coming in. He feels very anxious, doesn't have any nausea, vomiting, or abdominal pain. We found out that he has a history of depression and bipolar. About 4 years ago, he tried to hire someone to strangulate him and then failed, and he's still alive now. He was on valproic acid and aripiprazole, was not adherent, no allergies, no other drugs, and denies any family history. And I'm going to put it out there to the chat as well as the audience. What is our preliminary problem list so far? Okay, unknown toxic ingestion. Anything else? And he tried to kill himself. True. Perfect. Exactly. So what are our initial interventions? We don't know how much he took, but it looks like he took like an entire full bottle. So we put him in the critical area, put him on a cardiac monitor, established IV access, put him on a 1-to-1, and did an EKG. So our physical exam, he's anxious and tearful, but he's non-toxic, he's obese. His pupils are pretty much equal. They're not pinpoint or dilated, no jaundice or pallor. There's no signs of trauma on his head or neck. His lungs were clear, no murmurs, no JVD. His abdomen was pretty much soft, non-tender, no guarding. He's warm, he's dry, no pitting edema. His cap refill was also normal. And his neuro exam, his AO ×3, speech is normal. He's moving all fours, and he doesn't have any deficits. So what are our differentials so far? I'll put this out in the chat as well. Yeah. So some patterns of toxic ingestions come in certain patterns, and you can sort of group them out to anticholinergic, cholinergic, opioid, sympathomimetic, and sedative. And they have certain patterns, which you can sort of see here. Anticholinergic, you'll have like elevated heart rate and diaphoresis and elevated temperature. Cholinergic, decreased heart rate, pinpoint pupils. You'll be sweating a lot. For anticholinergic, you'll be dry. For cholinergic, you're going to be wet. And opioid, you'll have pinpoint pupils, cool, you will be dry as well. Sympathomimetic, you'll be warm, dilated pupils. This is also wet, and sedative, your respiratory rate and heart rate will be decreased, and you'll be dry. So what are the over-the-counter sort of drugs that can sort of group into these categories? So for anticholinergic, you could have some Benadryl. Cholinergic, there could be some mushrooms that he might have ate, who knows. Sympathomimetic, you can have some caffeine, and sedative, you can have alcohol. But he doesn't really fit into these toxogens, so what else should we be looking for? Yeah, Tylenol, anything else? Aspirin, yeah, totally. So this is actually the exact bottle that he came in with. He took an entire bottle of 500 milligrams, 100 tablets of coated tablets inside of the drug packs, it has 500 milligrams of aspirin and 32.5 milligrams of caffeine. So he's rock stable for now because he took it like a half hour ago. But what should we be anticipating? This is the EKG. Can someone tell me what they see? How's the rate? Okay, so normal rate. Rhythm? Sinus and access is pretty normal too. So this is like a pretty much normal sinus EKG. But considering that this is a tox case, we should be looking for certain patterns. So things that can cause like bradycardia could be like a calcium channel blocker or a beta blocker. Any sodium channel blockers like TCAs, any anti-dysrhythmics, even Benadryl can cause elevated prolonged QRS as well. And any potassium efflux blockers can cause prolonged QTs. And Dr. Silverberg wrote, the major reason to get the EKG is to look at the EVR, making sure that there's no terminal 40 millisecond positive deflection to rule out a TCA toxicity. So further testing and consultations, we ordered some basic labs, CBC, CMP, coags, a gas and a lactate, a tox screen including a Tylenol level, salicylic acid level, alcohol, X-ray, and we called the Poison Control Center and nephrology. So on reassessment, he looks a little bit more tachypnic. His other repeat vital signs are pretty normal, and he had a small volume emesis. All right, this is the results of his blood test. Can someone point out to me what's abnormal? Yeah, salicylate level, anything else? So he has a slightly elevated anion gap as well. And for the salicylate level, what's the normal reflex is under 20 milligrams per deciliter actually. So what's our updated problem list? Yeah, so he has an anion gap, he's tachypnic, and his salicylate level is also elevated. So this is like a patient that I actually got, and we anticipated and discussed with the patient given his, his amount of ingested substance. We actually attempted activated charcoal first, and we actually had a really long discussion about whether we should we should electively intubate him and do a gastric lavage. We also talked about giving him sodium bicarb and possible dialysis for this very lethal ingestion of salicylic acid. So we called the Poison Control Center. They calculated out that for the amount of aspirin that he took, the concentration that would be in his body would be lethal. For the caffeine, it will be 3 grams, but I think the aspirin level is actually a lot more concerning. They recommended us to lavage until gastric contents were clear, and also to alkalinize the urine, which we'll go into in a little bit. However, it's sort of difficult to estimate the salicylate concentration based on the dose because the volume of distribution changes based on the patient's acid-base status. Because usually the level would drop as the patient develops respiratory alkalosis, but as they become more acidotic, the level is going to increase. All right. So this is our course. We actually electively intubated this patient with etomidate and rocuronium. We primed the propofol to make sure that he's comfortable, and we put the vent settings to maximize the minute ventilation to prevent worsening acidosis. We gastric lavaged about 30 liters and took a lot of pill fragments out. We gave him a sodium bicarb bolus as well as maintenance. We placed an A-line for monitoring and 1 to 2 hour lab draws, gave additional activated charcoal, and admitted him to the ICU with renal on standby for dialysis. The first blood gas that we got was hemolyzed, but this is our ABG after the intubation as well as the sodium bicarb was given. His lactate was 6.3, potassium was 3, and his glucose was elevated at 2.4. And we'll talk about hypokalemia as well a little bit later, but today's topic is acute salicylate toxicity. And we're not going to be talking about caffeine in excess. It can cause like tachycardia, tremors, and hypokalemia and seizures, but I want to focus on the salicylic acid pathophysiology. Keep calm, and there's no antidote. So this is something that we need to sort of act fast and sort of get consultants on board to help the patient to have a better outcome. Salicylic acid toxicity, has been seen in the United States about 148 per million. In 2018, about almost 30,000 patients with intoxication exposure was because of aspirin, with a 0.4% mortality rate. And aspirin has been used for over 3,000 years as an analgesic, but also functions as an antipyretic and antiplatelet agent. Its function is to inhibit the oxycollagenase enzyme. And our discussion objectives is to go through the pathophysiology and toxicokinetics of salicylic acid, discuss the management and resuscitation protocols, and go over the basics of gastric lavage, which we don't really use anymore. All right. So this is a nice diagram. Basically, salicylic acid acts to uncouple and inhibit the oxidative phosphorylation in the mitochondria. And this leads to the accumulation of lactic acid and pyruvic acid, in which causes a primary elevated anion gap metabolic acidosis. Whenever we have a metabolic acidosis, we sort of have to determine if the decrease in CO2 is a compensation or if there's another primary acid-based disturbance that is associated by calculating the delta anion gap ratio. Patients with salicylate poisoning will often present with a normal pH to slightly alkalemic. Those who are acidemic on presentation are likely already sort of on the edge and critically ill. Of note, we have to keep in mind that salicylate can also interfere with the assay for chloride, which can cause a false elevation to make the anion gap appear as normal. And hypokalemia is also concerning and common due to the acidemia as well. Just plugging in our patients' labs. It looks like when we did the delta ratio, it sort of calculated out to be a non-anion gap metabolic acidosis, but maybe because it's too early to see. And what aspirin does is that, like I said, it uncouples the oxidative phosphorylation in the mitochondria. This leads to increase in lactic acidosis in the system, can cause fever. It also does medullary stimulation in the brain and can cause tachypnea and result in respiratory alkalosis, which would predominate early. And then as well as it also increases renal bicarbonate excretion, which causes the metabolic acidosis as well. And all this in turn can cause nausea, vomiting, diaphoresis. It can cause deafness and vertigo, can cause agitation and delirium as well because of the effects on the brain. So this is the exact things that I mentioned. Of note, the hyper and hypoglycemia is significant because the aspirin impairs glucose metabolism, and the glucose metabolism in the brain will tend to be low. So for the toxicokinetics, the therapeutic range of salicylic concentration is 10 to 30 milligrams per deciliter, and the concentrations that are greater than 30 is associated with signs and symptoms of toxicity. Rapid absorption in acidic environments happens with aspirin toxicity. You can usually measure its levels within 30 minutes. It peaks around 6 hours after the absorption. Of note, it can be delayed if it's enteric coated, just like the one that our patient has. And also, it's hard to measure the level because if in large doses, bezoars can form, which can make the measured level inaccurate. And the volume of distribution is 0.1 to 0.3 liters per kilogram. Of note, salicylic acid can cause pyloric sphincter spasms. So the more time it is in the stomach, the more absorption time it has. And elimination is also further delayed in patients with underlying renal and liver disease. So the way it's eliminated, it's first order kinetics, it goes through the liver. But when it's saturated, it changes to zero order kinetics. And this, is very, very concerning because now the salicylic acid level will move into the extravascular spaces, AKA the brain. However, when you start alkalinizing the urine and enhancing renal elimination, this becomes first order kinetics. So what's the tipping point? So the initial symptoms include like nausea, vomiting, headaches, and hearing ringing. But this can progress to really fast to altered mental status, tachypnea, ARDS, and death as the anion gap metabolic acidosis worsens. So what's our initial management? I want to go over through the ABCs and resuscitations, the methods of decontamination, the how to alkalinize the urine and serum, and then how to also eliminate the salicylic acid from your system through dialysis. So ABCs, historically, we're taught to really avoid or delay intubation as much as possible, unless the patient is hypoxic, has declining mental status, seizures, hypotension, hypoventilation, and fatigue. This can really cause, once we sedate and paralyze the patient, hypoventilation during an apneic period really can cause a respiratory acidosis and can lead to possible cardiac arrest. So there's this controversy here, like, should we have intubated this patient or not? Because the reduction in respiratory rate, like I said, can trigger a pretty bad death spiral. You'll have a patient who's acidemic initially, then you'll have greater entry of salicylic acid in the brain, which can cause severe CNS dysfunction, which can reduce respiratory drive, and then you sort of go in this vicious cycle, and the patient can code right in front of you. Even before thinking about intubating the patient, we had to give him antiemetics and give him IV hydration as much as possible, because hypovolemia worsens salicylate toxicity and impairs the treatment and measures in alkalinization as well. Of note, you have to correct the electrolytes, especially hypokalemia, because they exchange protons for potassiums in the urine. So you have to replace the potassium in order to even try to alkalinize the urine. All right, so I want to talk about gastric lavage. This is a gastrointestinal decontamination technique that aims to empty the stomach of toxic substances with sequential administration and aspiration of small volumes of fluid through an orogastric tube. This was first described in 1812, has been around for over 200 years, but most studies are pretty much flawed and have variable incomplete return, less than 50%, even after 15 minutes of doing it. And the patients can also rapidly, and also the utility of this rapidly declines after the first 1 or 2 hours. Only in certain rare cases, for immediate stomach emptying within 1 to 2 hours, and of an ingested overdose, and poisoning without an antidote. Like I said, the amount of toxin removed is unreliable and negligible, especially after the first hour. So this is a gastric lavage kit. We currently don't have one at Kings County or at Downstate. I think at County, we're working on getting one. But ideally, it comes in 2 parts. It comes with the lavage tubing, You want at least a 32 French or a minimum 28 French tube. And the kit comes in like two containers, one for the solution and one to empty. And we did discuss, conscious sedation for this patient, given the amount of ingestion, but we didn't know how long the lavage was going to take. So we opted for a definitive airway instead. So we, measured the length of the tube required to reach the stomach externally. We set up the apparatus with an IV pole. We pre-filled the solution bag. We made sure the patient had sodium bicarbonate in the system before going forward. We made sure the X-ray was readily available. And like I said about conscious sedation, even in a cooperative patient, is not really easy. It's kind of like putting in a chest tube in someone's esophagus while they're awake. It's very difficult. And if this is an option, we can consider ketamine to prevent respiratory depression. But like I said, the duration of the lavage is unpredictable. For the patient that I had, we lavaged him for about 3 hours. So it was like almost impossible if we had to do it with conscious sedation. All right, just wanted to go through some of the techniques. You want to secure the airway, give him a bite block, kind of the same one you would use in an endoscopy. We used a DL to insert a large bore 36 to 40 French lubricated tube. Like I said, the minimum you should use is a 28. Gently into the esophagus and stop if there's any resistance. Have the X-ray ready to confirm the position. You sort of want to position the patient. When I was looking this up, some people did it in like a left lateral decubitus position with a 20-degree head down. But what we did was we did him sitting upright at 45 degrees to prevent aspiration of contents. There was a lot of videos out there, but a lot of them are pretty outdated. So I wanted to show you what we actually did. All right, so here's the IV pole. You need a Y connector. Here's the patient. Yeah, the videos I saw were just like too old. Okay, so you're gonna have like this blue tubing, and this is where your solution is gonna go to. This fits about 3 liters of normal saline. All right, 3 liters. Some people asked like which solution should you use? It could be normal saline, sterile water, or even tap water. The point is to put it in and to take it out. All right, and then on the bottom you're gonna have a red waste one, and that's the exact color that they have in the kit. All right. So with the solution, you're gonna have a tubing that goes into the Y connector. And then the Y connector, this one is going to be attached to the patient's tube that you put in. And then the third one is going to be attached to the waist. And on each one, so towards the patient and towards the waist, there's going to be 2 clamps. 2 clamps here and 2 clamps here. And basically what you do is you fill, you sort of put in, it's suggested you put in like 200 or so. We actually put in 500 because this guy was a big guy. So you would put in 500 while you clamp the bottom. So you clamp the waist, put in 500, then clamp what's going to the patient and unclamp what's going down to the waist. And that's how sort of you lavage, and you just keep doing this constantly. Yeah, sorry for my terrible drawing.
How are you like introducing the lavage stuff? Are you like pushing it with a syringe?
Oh no, this is all gravity. So this is actually hanging through the IV pole. Sorry. Yeah, so this is hanging through the IV pole. So it's all gravity. Yes. And then as you're pumping the patients out, it's also gravity as well. How do I get back to my slides? Wait, how do I get back to my slides? Thank you. Yeah, so this is sort of how some people do it. Like I was thinking about ways to jerry rig it, but it's almost impossible without like a proper kit. Like yes, you can put a chest tube in someone's throat, but the chest tube is not long enough. It's not 60 centimeters. The OR at Kings County, they have a bariatric bougie that might work, but the end tips of the bougies are not big enough to take out the pill fragments. But we're working on getting a kit. Oh, this was at NYU Lutheran. Yeah, Tox. Yep. My mouse. Okay. So this is actually the exact pictures that I had for my patient. It was pretty impressive with the amount of pill fragments that came out. We gave him activated charcoal first, so that's why you see like all the black mixed with the pill fragments. We had to constantly sort of be at the bedside and irrigate with the Toomey syringe, which is like a 60 cc syringe with the pointy tip, because we were getting lots of clunks because of the activated charcoal, as well as early bezoars forming. And we lavaged like 30 liters and we're still getting out pill fragments until the stomach became clear. So I also want to talk about other ways of decontamination with activated charcoal. Technically, we should be considering this within 2 hours of ingestion. It's 1 gram per kilogram up to 50 grams PO with the initial dose, and afterwards you can have 25 grams PO every 2 hours or every 3 hours, or 50 grams every 4 hours for 2 doses. However, multi-dose activated charcoal is controversial as well. Of note, the first dose, like the one that we use, which is the Actidose, this is mixed with the sorbitol. You don't want to give multiple doses of sorbitol because it in itself can cause fluid and electrolyte shifts. So this is how activated charcoal sort of works. It doesn't fully prevent the drug from leaving the stomach, but hopefully it'll pass through the intestines and exit the body with the charcoal at like bound to the end of it, which will prevent it from passing from the lumen of the GI tract into the body, and prevent like the absorption of the drug. I also looked at whole bowel irrigation, which is not really used as much anymore. You basically you can use Go Lightly and sort of have them like poop everything out. The studies are very limited, and it can decrease bioavailability, but it will increase the absorption. So there's no really benefit in using whole bowel irrigation in the routine management of a poison patient. One of the important aspects of doing the intubation and during the lavage process is managing the vent. And I want to emphasize that we have to aggressively set the ventilator for a high minute ventilation for the initial setting. So increase the respiratory rate as well as the tidal volume. And also have O2 capnography monitoring, and having an A line for serial blood gases and blood draws. It's sort of easy to get distracted by like the novel or rare aspects of like doing the lavage and all these things with that, and like forgetting the vent. But if we miss compensating for the respiratory acidosis, this can be really fatal and highly morbid for the patient. Some types of elimination, which is super important, is alkalinizing the serum and the urine. This helps change the state to prevent neurotoxicity and enhance elimination through the urine. Basically, what this does is that a lower pH favors the ionized form of the toxin, which makes it more available in the body. And if you alkalinize the urine, it'll create less tissue penetration as well. And the toxin or the acid will be trapped and excreted in the urine. So what's recommended is you bolus the patient with 1 to 2 milliequivalents per kilogram of hypertonic bicarb, and 1 amp is 50 mLs. Afterwards, you give the patient maintenance, so a bicarb drip, which you can mix with 3 amps to 1 liter of D5W. You want to use dextrose because normal saline would make the solution hypertonic. The patient can also become hypoglycemic as well as glucose is used more by the brain. And the last efforts of elimination is dialysis, which is recommended if the salicylic level is greater than 7.2, and basically X-trip is this is a place that sort of has recommendations per toxin and what concentrations you should consider dialysis for in any kind of toxic drug. Labs and targets, you do want to measure blood every 1 to 2 hours, maintain moderate hyperglycemia. You want the potassium to be elevated at 4 to 4.5. And you want to alkalinize the urine until the urine pH is greater than 7.5. So even though our patient sort of like looked completely well, it was because he presented at such a short amount of time that we even considered the gastric lavage for him. His initial labs, sorry, it's read the opposite way, but his potassium was low at 3, and it was sort of low until we sort of replaced it. His first lactate level was 6.3, and then repeat that. This is after after maybe an hour into his intubation, was 3.5. And even though his initial salicylic acid level was 7.5, the second one that was done just 3 hours later was 33.1. So this is his sort of course in the ER. We intubated him, we gastric lavaged him, we gave him sodium bicarb, and we called the ICU. We did give activated charcoal first. However, if possible, lavage should be done before activated charcoal is given. But even if we did give it, we should still do it, the lavage if it's indicated. We corrected his electrolytes, including potassium. His urine pH, the first urine pH was 8. Afterwards, while he was in the ICU, psych saw him. He was extubated after 2 days and was discharged to psych. Some take-home points about salicylate toxicity and gastric lavage. To anticipate, what can go wrong and to call toxicology and nephrology early. Think through all the management options. Avoid intubation if possible, but if you do, maximize the mid-ventilation. Replace electrolytes, especially potassium, as part of the resuscitation, and sort of be familiar with the gastric lavage basics. And thank you so much. Here's my drawing. I don't know if you can see it. You can. Any questions? Yeah.
First of all, excellent. Great. Graphics, incredible.
Wait, can I put it back up on the screen? David, how do I do it? Sorry, MJ, go ahead.
No, my only question was like if you come across anything about using Toxicology during awake intubations because of the possibility of laryngeal spasm and apnea with ketamine, because then that can worsen your acidosis and cause intubation, intubation.
I'm not too sure, actually. I'm not too sure. I don't know if anyone who helped with my lecture have any comments on that. Yeah. When he presented at 30 minutes at NYU, things happened a little faster. So he got it almost immediately, while we were just deciding whether or not to do the lavage if we had a kid or not. So I think even though it was with a little bit more than 1 hour of ingestion that we performed the procedure, I think because of the amount of ingestion, it was definitely important that we sort of did it. Dr. Chan.
So we're going through the optimization of gastric lavage,
Yeah, so we called renal super early just in case, but his initial labs were great and he looked great. Well, he actually consented for the lavage and everything too. So renal was always there in case we needed him, but after like within 4 hours, his salicylate level dropped. So it was 7.5 to 33 to 30, and then down to a single digit within a few hours. Yeah. Any comments, Dr. Sinnott? I was very curious. All right, thank you so much.